Right then, hi everyone. Thanks for coming. My name's David Evans. I'm Deputy Director for Deployment here at Health Innovation West of England, and I hope you're all having a really good day so far. I'd also like to wish you a very warm welcome to this afternoon's panel session, which is focusing on how innovations can be adopted and spread into our health and care systems. So we would like to discuss how innovators can be better prepared to work with health and care providers, and how health and care organisations can better support the adoption of proven innovations into their businesses. So the aim here is to have an informal but stimulating conversation. So I'm absolutely delighted that I'm able to introduce you to a very interesting and esteemed panel for the session. We've got two of our keynote conference speakers and a highly successful innovator who we at the Health of Innovation West of England have worked with over the past 10 years. So, introductions. Ladies first, Verena Stocker is Director of Innovation Research, Life Sciences and Strategy at NHS England, and also Managing Director of the Accelerated Access Collaborative, which has done so much fantastic work in helping to spread the use of innovations across the NHS. And I know prior to this, Verena has held a number of senior roles at NHS England. You're very welcome, Verena. Next, we all met Hassan earlier. I probably haven't got a card long enough for all the roles you've got, Hassan, but co-founder of Vita Healthcare Solutions, Commercial Director of Data CAN, and Head of Commercial for Great Ormond Street Hospital for Children NHS Foundation Trust. As we know, Hassan is also an entrepreneur and an advisor in global health with a background in frontline social work, NHS informatics and public health. He knows some stuff. You're very welcome. Thanks for coming, Hassan. And last but definitely not least is Dr. Kerry McClellan. Kerry is Chief Exec and founder of Get You Better, which is a digital self-management platform that helps people with MSK injuries and MSK conditions. So Kerry's a physiotherapist by background, and he has a PhD in health economics. He's a visiting research fellow here at the University West of England, and also an NHS Innovation Fellow. So can I ask that we just encourage our panel members with a big West Country welcome. or maybe for Hassan, I should have said a big wild West Country. So I'm going to ask first question to Kerry. So what we're going to do is invite you to ask questions from the audience. We have a QR code here, or if you can go to slido.com on your phones, the code is #789. And we would love to have as many questions as possible. Meanwhile, while you're doing that, I'm going to ask Kerry the first question. Kerry, can you tell us about some of the specific barriers and challenges you have faced trying to establish Get You Better across the NHS?
In about 60 seconds?
We've got 75.
Yeah, no problem. Of course, and when I knew this question was coming, and so starting to think about the barriers and challenges, it got broader and broader and broader, and I think they basically fit into three camps. The first one would be the early adopters. So those that are in the early adoption of technology, it is getting harder at the moment. For early adopters, there's a funding, there's a capacity issue on the ground to deliver innovation and technology. The integrated care systems have been going through significant change over the last 2 years, and that has led to a lack of capacity to deliver projects. So we're now having conversations about, well, who's going to deliver the project? And that becomes quite a big barrier, really. The integrated care systems, which would obviously want to adopt technology, they're all different. Culturally, readiness in their maturity, in how they're able to onboard and pull in technology. And it's very, very hard for innovators to navigate that specific kind of minefield, if you like. And it's very hard to choose which ones to actually go to, really. The last bit, or a couple of last things, I think, if in this section, would be data. We get a very high level of scrutiny. We have to provide data to demonstrate impact, often cash releasing in year. But when we actually ask the integrated care systems, and sometimes NHS England, they don't know how to measure it either. And so we're being asked to measure something that nobody knows how to measure or demonstrate the value and benefits of the NHS and its patients. The second thing that I think we've found is there is a second innovation chasm here for innovators. We are an early majority, so we're in 40% of the NHS. And recently, we've found another broad and wide barrier to have to overcome, because the ICB is in such an era of change that innovation is often the first thing that goes. So it's even harder, and it's a bigger barrier. And the last thing, very quickly, is digital inclusion. The NHS needs to change its approach from the bottom up, with education and teaching of clinicians how to use technology, how to adopt it, its benefits, manage the negative beliefs. Because believe it or not, we've just published a paper this year on digital inclusion, and everybody was shone a light on patients. But actually, if you started to shine the light back to the NHS and the clinicians, they were actually part of the problem to digital inclusion. They were excluding people that actually would benefit. So I think there's broad early adoption, there's later adoption, and there's actually the way that we work, challenges and barriers for innovators.
So lots for people in the NHS to be thinking about in terms of how to work with innovators more productively. Okay, I'm going to ask the next question as we're collecting questions. Can you hear me okay? Yeah. I've got a booming voice. I'll manage without a microphone. Verena, I was going to come to you. Kerry's been talking about his experience in terms of trying to spread the use of or scale up the use of his digital app, and I know you did some. You led a very successful review around digital transformation within NHS England. So we know digital technologies have and are transforming the way we live our lives. And it's top of the NHS agenda that's been coming down from government in terms of the move from analogue to digital. Could you paint a picture for us in terms of what you think, or how you think digital might influence how we make NHS services more efficient over the next 5-10 years?
Yeah, I would love to. And can I just check, did anybody read the Laura Way-Geary review, Putting Data, Digital and Tech at the Heart of the NHS? It's the one that Dave's referring to. A couple of nods. So just a quick recap, because somebody asked me about this the other day, and I realised it's about 6 health secretaries ago. So it was commissioned by Matt Hancock, if you remember him. But we ended up presenting it to Sajid Javid. So that shows you what happens in a year in politics sometimes. And essentially it was looking at what changes do we need to make to the NHS to harness this kind of digital revolution that we're experiencing. And there were a couple of recommendations that came out which I think are pertinent to my response to that question. So the first actually builds really nicely on your point, which is the culture, skills and capabilities that are required in the NHS to harness this. And actually we very much focus on the workforce rather than the individuals, the patients, because our kind of ingoing assumption was patients are actually asking for this in many areas because they're experiencing it in other parts of their lives, whether it's kind of banking or grocery shopping or other kind of avenues. And so we put forward the argument that we really need to think about training up and upskilling people in digital kind of methodologies and techniques in the same way we would about finance, which is there's a minimum level kind of understanding required at all grades in the NHS. And then dependent on your role or your level of seniority, you may need more or kind of less skills. We also spoke about this idea of digital not being seen as something over there and other, but that it needs to be seen as a core part of delivering services in the NHS. And I don't know, it depends who you are, whether it's fortunately or unfortunately, part of that recommendation was a structural merger to bring NHS Digital and NHSX into NHS England. And the main reason for that was to stop this kind of lobbing over the fence of, well, this is the digital kind of team's responsibilities to look at implementation, uptake, and how we're addressing kind of business need. So really kind of core part of that. And then the final kind of area was around funding. So this, the requirement to have sustained, if possible, ring-fenced multi-year funding, which we've been less successful on, if I'm being very candid. Financial picture, as I know you all know, is quite bleak. That definitely impacts digital budgets. And despite that kind of context and they're the kind of core recommendations that came out, we've made progress in some areas. We certainly within NHS England view digital transformation as being key to improving productivity. we look at it really from a couple of different lenses. So there's kind of core digital infrastructure that we need, and I would put data infrastructure in that same category, whether that's the federated data platform or the secure data environments, depending on your use case for data. We're also then looking at connecting, so kind of the interoperability challenges that we're all really familiar with, and then also looking at the transformation side. So when I think about productivity, I'm thinking a lot about things like the non-clinical facing things that we can do to make people's lives easier, which from my perspective should be part of a workforce retention type offer. So automated discharge letters, ambient voice technologies, those type of things that can make clinical lives easier and improve productivity, as well as improving access through things like the NHS app. Got 75% of the adult population using that. It's a great way for us to try and improve access for a number of people. So we really see technology and actually harnessing data more generally as being completely pivotal to the productivity agenda. The question is just a funding one. So how much do we fund on the infrastructure side versus the more transformative side?
Brilliant, thanks Verena. So I was going to ask one more question before I open questions up to the audience, but just to let people know in advance, we're going to have to let Verena go 10 minutes early because she's our keynote speaker and she needs to get back into the main hall and get mic'd up and in the zone. Hassan, I loved your. I think we all loved your presentation earlier on, and certainly the blog you'd sent me in advance just resonated so much. And I just wondered what you think the American Railroad solution might look like across our health and care systems to help accelerate the adoption of digital health solutions.
Thank you. So I recognize a trend, which is why I wrote about the train tracks. I think it's already happening, and if we're not careful, it will happen in a way that we don't like, where a vendor that has 70 deployments will then say to everybody, why don't you piggyback on me? Then they will end up being the gatekeeper. And I don't want that to happen. I want us all to recognize that the future is going to be some form of infrastructure where it isn't just a plain platform, it's a platform for point solutions. And therefore we all decide what that should be. And there should be multiple versions. I don't think it should be a single one either. The reason why I would like to go narrow for a second is because I think there are a number of use cases. So the one that I'd like to focus on for a second is pilots. And some of you may have heard me speak about this in the break and other conversations. I think pilots hurt innovators because there's a lack of clarity about what's required from this pilot. There's a lack of certainty that it will lead to a deal and a lack of financial commitment to you actually signing a deal afterwards. And if we ended up saying, if you sign this deal, let's just call it the Dave, this
won't sell much.
So the Dave is an innovative new contract. That means an innovator like Carey can sign it because the organization, for example, a trust, is saying, we commit to giving you this contract if you fulfill these conditions. It's contingent. But if you do so, and we stack the deck to make sure it's de-risked, then you get your contract. At which point, Carey doesn't have to think, will this pilot convert? And then do I have to end up doing 7 or 8 or 10 more pilots, collect data in different places, be told by Newcastle, well, actually, they're different, do it here, collect more information. That ends that roundabout. Now, that's only one element of it, but clarity, certainty, commitment, contingent, there's lots of C's there. I wish someone had come up with that, and they haven't. And I sometimes think maybe I'm really stupid for coming up with this idea. How come no one else has? Maybe they've worked out it doesn't work. But when I put it out into the world, I think a lot of people say, yeah, that would be good. So my request of everyone here is for an innovative HIN, a group of people who really support each other, is to think differently, because you have the right to think differently and make it work.
Fantastic. Thank you. Thank you very much, Hassan. So we've got a bedrock there for some interesting conversations, haven't we? So I'm going to go to the floor now. Now Becky is collecting questions off Slido.
Yeah, we have quite a few on there already.
Good.
If there's any in the room, I can go to the room first. If not.
Anyone in the room have a question? Yes. And we have a microphone for you. Becky's going to walk around. She's going to get her steps in today.
So Nick Dockers, XGP MedTech Innovator. One of the problems with digital innovation is the infrastructure that we've got at ground root, grassroots. So until we've got that better than the ambient of the listening and things like that, and dictation, it's not happening. So It's obviously something that's pretty important. Is there likely to be an answer to that?
Sorry, who's that question to?
To me, probably.
Yes.
It's really, I mean, so completely agree is the first thing I should say. It's why I frame it, so politically when we're making this argument in a really tight fiscal environment, we talk about those three different kind of areas to focus on, kind of foundational, the connection and the transformative. And we really make the argument that politically, obviously, there is a temptation to go very much on the transformative end because they make really good announcements, it resonates to people, they're often the really kind of patient-facing elements. But without EPRs, without the data architecture and data infrastructure, those things are incredibly difficult, if not impossible, to implement. So we're consistently making that argument. So far, certainly, that's been well received. I think there is a recognition of that. It just then gets into quite tricky territory around things like fiscal rules, capital revenue splits and all those kind of things, but we are actively making that argument. I feel optimistic about it, but I'm also conscious, as I've said a few times now, the fiscal environment is tight. Those things also tend to be quite expensive. And so if I think about a certain program like the Secure Data Environments, which is a part of the data architecture, the language we're using is this is like national critical infrastructure, and it should be considered in the same sense as we would physical infrastructure in that sense, which is long-term, sustained investment from the government. And we're hoping that really resonates.
Fabulous. Thanks, Verena. Becca.
My question leads into that, actually. Given the fiscal environment, what are your strategic priorities to ensure that the NHS achieves its ambition to be world-beating in test, change, innovation, and the spread of that as well?
Yeah, I think we're getting our money's worth out of you, Verena.
This is going to make the next half hour completely redundant. So I'll do a haiku version when I get in there, and I'll defer all questions to this group. So a couple of things. So first of all, focusing on the foundations. I won't repeat that, but that is part of it, right? To say that even in a really fiscally constrained environment, you need to do that, because if we don't do it, no one else is going to do it. Often that really foundational stuff is not an area where we can get inward investment in, because it's not necessarily that attractive. Things that improve productivity, kind of a big tick. Now there's all sorts of discussions around what does productivity mean, how do you measure it, over what time horizon. And again, we're trying to make the argument that if you look too short term at that time horizon, it's incredibly difficult to find innovations. And then the key thing we're trying to do is be much more demand-led, so to be clear out to industry to say, in a really constrained budget, these are the things that we really want innovations to focus on, to be really clear about that, and hopefully provide some consistency over multiple years, because that's what we obviously need industry to know, which is this hopefully won't change in the next 12 months, 24 months. So I think they're the key things we're trying to really argue for off the back of the settlement we've just received.
I think we've got a follow-up question to that. Carol, do you want to introduce yourself as well?
Sorry, hi, yeah. So I'm Carol Roberts. I work in digital health, but within Bayer as a pharmaceutical organisation. But we're very much focused on digital health, and I think where we found is that you say, yeah, the physical thing is productivity, but actually we're finding that we're getting challenged that if it isn't revenue releasing, as opposed to resource releasing is trumped by revenue. And of course, with an endless bucket of demand, you release resource, it just gets filled. And so, when is there a move to change the conversation to resource releasing being what you need in order to be able to tackle the backlog and to improve outcomes in long term, because the longer obviously you leave the backlog, the worse the outcomes. How can that happen? Because we're being blocked everywhere saying it doesn't matter if it's resource releasing because it still costs money because the resources get used.
Yeah, please do, Verena. I'm wondering if
Sorry,
they're part of the same art.
That was just
Part of the same
Anyone
thing.
else want to take that on?
I was about to say it's the last time I come to Bristol. But at least it's made the train trip worthwhile.
No, so this is a challenge. It's why I kind of smiled as I said there's kind of discussions happening about what that means, because you're right. So because of the situation we're in financially, with ICB deficits, which is nationally the challenge, we're picking up obviously pay inflation costs and other things like that. It is very much looking at revenue releasing for the time being. There's a question mark around time horizons. Is it in year? Is it across 2 years, 3 years? We've got slightly different definitions in the medtech funding mandate, for example, versus the proposed rules-based pathway. Because there is also this question around workforce productivity, I think we're increasingly looking at broadening that definition to think about, does it release time to care, is the language we use, but I think it's getting to the same sentiment. My very candid thoughts on that is it'll depend a little bit on your local system and how financially challenged they are. This gets to your variation point that you mentioned this morning in terms of how receptive they are. But I think increasingly we'll be looking to that as being an additional thing that we factor in. I wouldn't say that it would trump revenue releasing, but I think it certainly would be considered as part of that.
Okay.
Thank you. And I think, Sarah, did you want to come back to Verona? Sarah, next row back, please. Becky. Yeah, you, Sarah. Yeah.
Hi, I'm the Chief Medical Officer at Bristol and Somerset, South Gloucestershire, and I was really struck, Sam, by your talk this morning and your comment about how difficult it is, talking to some innovators on the table, the bureaucracy they're having to go through is just an inhibitor, and we just have to accept it. And my question to you all as a panel is, how do we change the way ICBs have been structured around commissioning, contracting and procurement? Because if we take resources out, we have a team of, I think, 4 people who are doing all the basic BAU contracts and commissioning. There's no headspace to think, should we have a contract with an innovator that gives them a 3-year guaranteed income for establishment and return on investment? We don't have the expertise within the ICB infrastructure, at least on the single ICB. So what can we do to give the procurement, commercial, contracting expertise we need so that you've got a fertile ground to land with? There's no point having hundreds of innovations if they just keep going to waste. So we need to put some infrastructure around that, maybe at regional level, maybe at cluster level, that allows us to take this risk, change some of the procurement rules, and be imaginative in the contracting space.
Hassan, you're nodding vigorously there.
No, I completely agree. We can't expect the many different parts of the NHS, because we are not a single organisation, right? We can't expect everyone to replicate and duplicate the work. We therefore need some form of aggregation or centralisation of these key things and then decentralise them when they're ready. And that's why I believe the answer has to be de-risking the actual ask from an innovator, by which I mean, we say to an innovator, you must achieve these goals for us to give you the contract. And therefore we can load that with as many conditions as we like. But when it becomes clear, then another ICB or another hospital can then take the same form of contract and apply it. And if they say, well, I've achieved this contract, the Dave, and I've done it in 4 places, I want to do it in the 5th, their spread and adoption becomes easier. We talk about spread and adoption, but without the mechanism for scale, which is why I would like to see those kind of contracts. Procurement is actually even worse now with AI, because the problem is the product isn't the same. It's learning, and it's growing, or hallucinating. And therefore, procurement teams are now saying we need specialist support. And you can't have specialist support everywhere. And that's why I think centralisation in some form or another will become important.
Brilliant. It's okay, Joe? Thank you. Becky, another question.
Yeah, okay.
So we touched on the fact that 75% of the country use the NHS app, but that means therefore there's 25% that aren't. What are we doing about supporting those? What is our obligation around those people to make sure that we don't exacerbate health inequalities?
Use that question to
It's kind of open.
generally. Kerry, have you got any thoughts on this?
Yeah, I do actually. I mean, as innovators, early innovators or early majority innovators providing technology to the NHS, we get asked about this all the time. Are you going to integrate with the NHS app? Do you have NHS login? And the answer to that is the NHS app isn't ready for us to integrate with it, and it's not in a place where that can actually happen. So there's a little bit of a misunderstanding about that. And digital, those who are left behind who do not adopt is a perennial problem for innovation. It's not just the NHS app, it's everybody. And the answer to that is you have to provide alternative solutions for those that don't choose to do that. And it becomes part of routine care that there is a way to get people on board. For example, libraries. You know, we work in some areas where the libraries are teaching people to onboard onto the NHS app. Why not put it into the community, put it where people need it or they are reaching out? And the same thing applies to all technology. But The NHS app plan does not allow people like Get You Better to integrate with it at the moment because they've already got a schedule of work that's most probably looking forward to about 5 years.
Yeah, Verena, please.
And just to add to that, very much agree there needs to be an alternative face-to-face service. So it's not digital only. I think that's really important. And very much viewing the NHS app, it's 75% of the adult population as well, so it excludes children, just for clarity. So it's very much thinking about it picking up some of the demand, but not all of the demand. I also think user experience and user accessibility really key in that. So a lot of the team's focus, certainly within NHS England who develop the app, is looking at those two things so that it's by patient choice rather than because they can't, for whatever reason, use the app. So that's also another important consideration.
So may I just add one point very quickly? I like the app, but I don't think forcing ourselves to think about the app as a solution is the right way. I think solution forcing creates bad incentives. We should be thinking how we reduce the digital inequality, the digital divide. And when the app is the answer, great, use it. But sometimes I think we often are thinking how to push the solution rather than pull. And I'm really looking for a pull. I want the system to say what it needs. I want citizens to say what they need. And when that happens, the app will then respond. But I don't think us thinking about a solution, any solution, whatever the solution is, always works. I think it leads to odd intended consequences.
Okay, thank you. Looking out across the audience for hands. Nothing. So Becky, I'm going to come back to you.
Oh, I've lost my place. That's good. Hassan, I've got one for you around your train track analogy. So someone said the problem with train tracks is not the train tracks themselves, it's the fact there are not enough train drivers, leaves are on the track delaying the trains, an expectation of a lack of reliability. How can we change that? How do we make that different?
I like the way the analogy is going. It's really, it's really changing. I'm really looking. And I didn't use the word standardization, but that's what I meant when I put the loo roll and the USB pictures up. I am only looking for certainty and clarity and commitment that both sides of the vendor-buyer divide can align on. And I see NHS England and the AAC as referees in this conversation, trying to make the policy environment work for us. And the danger, for example, I'm a buyer at Great Ormond Street. When someone comes to me with an offer, I'm trying to work out how I can take that offer and win 17 arguments internally. How can I get the CIO to say, yes, I'm going to give some space and we're going to put it onto this server? How do I make sure that it gets signed off when it comes to the IG? We had one company that waited a very long time because it hadn't got a sign off from the DPIA. These kind of things delay you, right? And then they ruin your runway. And you can't really say to investors, well, they didn't sign the DPIA, I'm still waiting. That's a really embarrassing thing to say. But that's the kind of struggle that all hospitals have. So the standardization is what I'm getting at. We can go too deep into the analogy, but all I'm trying to get at is if there's no alignment, we all lose. The innovators will go to the US or they'll go to other markets. The health systems will then be stuck with what they currently have. And bad vendors who are in already monopolize on it. And I don't have to name them, but you know the kind of big vendors have taken a lot of money off of us and said, we're not going to give you what you want, wait till the end of your contract. And that's what I want to see an end of.
Thank you, Hassan.